Yes. I hope you guys aren't thinking, well, okay, now gastric reflux, that's, stomach acids coming up from the stomach and dripping down around the endotube and getting into the lungs. Are you thinking, well, that doesn't happen with every ventilator patient, therefore I'm not going to check it? I'm thinking that our test-taking skills here are veering off from what I'm expecting. We're looking for things that can lead to pneumonia, ventilator-associated pneumonia. We intubate a patient, we put them on the ventilator. Do any of these things lead to them getting pneumonia? I'm not saying that 100% of patients will have gastric reflux, 100% of the time that will end up in the trachea. I'm not saying that. So it's okay to select it because that potential is there.
It's a possibility.
Yes. The ventilator circuit that hasn't been changed in 2 weeks, will that lead to ventilator-associated pneumonia?
No.
Correct. The answer is no, so don't select that one. There is no correlation between what's in a ventilator circuit and a patient getting pneumonia. Used to be thought that it was, and we used to have to change the circuit every morning, but it doesn't cause pneumonia in a patient. The circuit will get contaminated with their own secretions and the bacteria that are already in their lungs, but it's not the other way around. It's not like you've got bacteria in the circuit that are given to the patient and causing their pneumonia. The heated humidifier won't transmit bacteria. Remember, water vapor is molecular in size. It cannot carry a bacteria. HME is going to filter any air coming into the HME and going to the patient. So you've got a filter right there. So the circuit does not contaminate the patient. Oropharyngeal secretions contaminate the patient, but not the circuit. So don't pick that. Deflating the cuff every shift.
Yes.
Yes. Inability of the epiglottis to function while the endotube is in.
Yes.
Yes. All right, what would you do if you add 5 centimeters water of PEEP and the patient's blood pressure drops from 120/80 down to 90/60? Select all that apply. A, increase the PEEP to 10 centimeters of water. You didn't have enough PEEP on.
That would make the situation worse, wouldn't it?
Very good. That would make things much worse.
Yeah,
Okay,
blood
so
pressure
don't
would-
select that.
Yeah.
B, decrease, decease, it's missing an R. Decrease the PEEP to 0.
Yes. That's
Yes. Recommend increased fluids and blood products?
Yes.
Yes.
right. No idea.
Calibrate the sphygmomanometer,
What is that?
a blood pressure cuff.
Oh, no.
No. A patient's intracranial pressure post-neurosurgery is 35 millimeters mercury. You would recommend, A, do nothing, just monitor. Do you remember what the normal is from your notes from last week? 20 is a normal intracranial pressure. So this patient's pressure is 35. Do we like that?
No.
No, that's not good. That's going to damage the brain, isn't it? So doing nothing and just monitoring isn't a good thing. Should we hyperventilate, get a CO2 of 28, and that'll vasoconstrict the blood flowing to the brain?
Well, we want blood flow to the brain.
Very good. We want blood flow to the brain. So that's an old practice. It's not done anymore. If it is done, it's only done for a few minutes at a time, not as a way of preventing high intracranial pressures. So don't select that. C, turn off the PEEP.
Yes.
That would help, right? Allow the blood to flow from the brain. Phenobarbital,
I have no idea.
that's a narcotic that slows down brain function and has some protective effects in the brain. I guess I can tell you about that. So yes, that would lower intracranial pressure. And suction the airway,
No, don't do that.
why not?
It'll increase.
Very good. Suctioning the airway causes intracranial pressures to go up. Yeah, so if you're working in trauma ICU, you've got a head trauma as your patient, patient's on the ventilator, and you come in, you listen to the lungs and hear some bronchi. Should you just go ahead and suction like we do with our other adult patients and clear the airway? No, so you want to check with the nurse first, because if they have an intracranial pressure monitor in, there's usually a port where they can drain some of the intracranial fluid, get the pressures down, so that when you suction, you're not causing a high intracranial pressure. So your head trauma patients, you check with nursing before you suction. Okay. Let's get started on the next one, and then we'll pause for lunch when Anita gives me the signal.